So we're going to talk about pneumonia. I've lost my red pen. Is it right there? Okay, thank you. So let's talk about pneumonia. Lord, I've got the chairs just a mess back here. I'll end up running over myself. Okay, so the assessments with pneumonia. The patient's probably going to come in. They're going to be presenting with some shortness of breath, complaint, maybe some coughing, fever, and those kinds of things. This is normally, it's not a quick onset. We usually see this kind of progressing, but it could be a quick onset. You know, it just depends on the patient and what the predisposing factors are. So the patient's going to come in, and we're going to look at their O2 sat, and we want to get a good health history, because a lot of these things can tell us what is going on with the patient. If they smoke, if they have asthma, if they're immunocompromised, if they have COPD, if they have anything of that nature, we want to gather that information whenever they come in. Okay, your book goes into all of the different types of pneumonia. Okay, don't get hung up on all of those different types of pneumonias. Community-associated pneumonia, people get it in the community. So they're going to be coming in to the ED or to the clinic or to the urgent care or somewhere like that, and they're going to be presenting if they have community-acquired pneumonia. If they have ventilator-associated pneumonia, how did they get it? From the ventilator, they're in the hospital, okay? If they got hospital-acquired pneumonia, now that could mean that they were in the hospital and they went home and then they developed pneumonia, so that's still hospital-acquired pneumonia. Or they were in the hospital for something else and they got pneumonia, okay? So could be a variation of reasons that they have pneumonia. If they have pneumonia, they've got to be treated and they've got to be assessed. So whether they come into the ED or they start showing clinical signs of deterioration where that you need to be intervening and figuring out through your assessment process that maybe they've got a pneumonia going on from something else. Maybe it's because they've been in the hospital and they are not moving around and they're not moving their airway, they're not doing good pulmonary hygiene through incentive spirometry, turning, coughing, deep breathing, ambulation. Those are all associated with pulmonary hygiene, okay? So all of those things are associated with pneumonia. So we've got to assess those. So don't get hung up on whether or not where this come from or what organism it was and what medication I'm going to give them, okay? Know how to assess these patients and how to look at those diagnostic studies and collaborate with the physician to know what's going on with the patient, okay? Don't get hung up on which type that it is and looking at all of those, because then you're not going to spend time on your assessment, your intervention, and your outcomes, which is your nursing process, which is what you need to do because you're the nurse, okay? So we want to know their health history. So smoking is a huge contributing factor to pneumonia, okay? It's also to COPD and those things. So we want to assess for fever, a cough. Is it productive or not? If it is productive, what do we want to ask? Okay, so the characteristics. So is it yellow, green? What does it look like? Okay, now they've got shortness of breath here. So what do we want to know about shortness of breath?
All the time, or whenever they're doing it too.
Exactly. Is it all the time, or is it with exertion? Okay, is it more when they're up moving around, or do they also have shortness of breath when they're lying flat? Do they need to be elevated? So when does this happen? Okay, so when? Crackles, wheezes, rhonchi. So we're looking at breath sounds here. So let's look at breath sounds and what do they tell us? Okay, so are the airways constricted from wheezing? Is there mucus in there causing the wheezing? Is there friction rub and it sounds like crackles in there? Do they have rhonchi because they've got mucus plugs in there? What is their breath sounds? And you've got to document those, okay? Use of accessory muscles. So those sternocleidomastoid muscles, those accessory muscles, you know, if they're short of air, then they're using those accessory muscles, all right? So they may have, they've got decreased breath sounds here. So those are going to go together, these breath sounds. Gag reflex. Why would a decreased gag reflex be important with pneumonia? Because of aspiration. Because they may have aspiration pneumonia. So we want to know, did they have, and so where would somebody's gag reflex be impaired? When would that be impaired? A stroke, right. So we may see that with a stroke. We may see it with some neurological disorders. We may see it several different places, okay? So diagnostics, we're going to get white count, and that's going to be elevated, okay? ABGs, so you may have abnormal ABGs. You may see consolidation on that chest x-ray, okay? And then your sputum culture. All right, so let's talk about a sputum culture. Your book really goes into detail about a sputum culture. When is the best time to get a sputum culture? First thing in the morning, and what do you need to instruct the patient to do? Not to eat or drink. Rinse their mouth first, and take a good deep breath and cough from deep, okay? You don't want saliva in there, okay? And if they rinse their mouth, that's going to rinse out any microorganisms that might be in the mouth, okay? I know sputum is gross. I don't know how these respiratory therapists do it. It's just gross. So interventions. So they've listed a lot of the antimicrobials here. So antibiotics. If it is bacterial, okay, so bacterial. All right, we can also give some Tylenol and ibuprofen. Now, they may need IV antibiotics initially and then switched over to PO antibiotics. So what are we going to teach them about antibiotics? Take them all, right. These people really need to promote rest and fluid intake. And the reason is that it's going to take a lot of exertion, a lot of energy for them to actually just breathe. Okay, so they need a lot of rest and fluid intake. Maintain nutrition. So if they can't eat, if you've got pneumonia and it's causing you're having to use accessory muscles, you're coughing constantly, it's really difficult for you to be able to have good intake. You don't want to eat. So what else could they do to maintain their nutrition? Okay, so supplements of some sort, so protein drinks or supplements. Okay. Complications. So what are some complications that we could see? They could deteriorate. They could go into respiratory failure. They could have to be intubated. Okay? So those are some of the complications. We want to combat those. Position to prevent aspiration and encourage coughing. So we want to definitely encourage these folks to cough. They need to cough, deep breathe, use that incentive spirometry, and those are priority nursing interventions. Those sound like really basic things, don't they? They sound just like basic things that you want to do. But, some of the basic things can just be the best things that you can do for your patients. Okay? Any questions about interventions or assessment? Okay, so let's talk about outcomes. We want their vital signs and their oxygen saturations and ABGs and their lab work to all go back to baseline. We want their cough to diminish. So we want their production. We want them to start coughing stuff up and get all of that mucus out of there and it to diminish and eventually go away. Hydration and nutrition. So hydration is also going to help to thin those secretions. Okay, so we want to keep them well hydrated. Now, these protein drinks, they may cause those secretions to be a little bit tenacious, sticky, and thicker. So, you know, if they're going to drink protein drinks, then they need to increase their fluid so that it thins those out. Okay, we want fever to decrease. We want the patient to exhibit an understanding of their treatment plan. I love that. I love that you all wrote that. Pediatric considerations. Hydration is really important because those kids can get dehydrated easier, a lot easier than adults can and a whole lot faster. And then your medication doses are going to be a lot different for these pediatric patients, okay? Because they are going to require some antibiotics, but that antibiotic therapy is probably going to be a little bit different than it is for adults, all right? So, questions about pneumonia. Just remember, you've got some collaborative interventions here. Okay, so who are you going to collaborate with out of these? Okay, so you're going to collaborate with respiratory.
Dietary.
Okay, so respiratory, dietary.
Maybe physical therapy, depending on how they ambulate.
Okay, so I'm just going to put therapy there because if this patient has pneumonia from being on a ventilator, or if they have pneumonia and they progress, and Lord, we're doing these interventions to keep them from progressing, but if they become really debilitated, then therapy, OT or PT, may have to work with them, okay?
If they're at risk for aspiration, would you have speech therapy?
If they are at risk for aspiration, definitely speech therapy. Because we want to, and we haven't gotten to aspiration. I don't even know where it is on the board. But, and what I'll do is when you all leave, I'll just stay and I'll finish recording these for you all, okay? I won't have any interaction unless anybody wants to stay, but I'll finish recording these because Kelly's here to talk to you all about the modalities. But that is a real important thing. So when I talk about aspiration, just remember that, you know, that protection is gone. So you don't want to take a chance on somebody aspirating and then, you know, getting aspiration pneumonia. So you definitely want to contact speech therapy, okay? Questions about pneumonia? Did I go too fast with it? All right.
Don, can you finish this up? So I can sit here while you finish that up and pick up as soon as you get done.
Are you sure? Okay. Well, we'll just keep going. We'll do a little bit more, okay? Because I don't think Kelly's probably going to take 45 minutes. Okay, so